Welcome to the webinar Dental Implants, a Team Approach. The lecture is being presented by Sable A. Muntean, DMD, MHSA, and we're going to begin shortly. And now it is my honor to introduce Sable A. Muntean, DMD, MHSA. Dr. Muntean graduated from Florida's Lecom School of Dental Medicine, earning her Doctor of Dental Medicine and Master in Health Services Administration degrees. She then completed an advanced education in general dentistry residency and an implant fellowship at Southern Illinois University School. In 2022, Dr. Muntean became the first full-time female dentist at the St. Louis VA Hospital and is currently chief editor of Ignite DDS's Get Lit newsletter geared toward new dentists. And now it is my pleasure to say, take it away, Dr. Muntean.
Thank you so much, Jessica, for this opportunity. And thank you, NDX, for having me. I'm excited to get going for tonight. I have my conflict of interest over there, and I'm not affiliated with anyone or anything that I'm presenting about. So feel free to ask me any questions. Like I said, we'll probably get to them at the end just because there's so much information. I just struggled with, taking out slides. So let's go. So quick introduction, just as to go off of what Jessica said. This is when I graduated from Lecom just about 7 years ago now. These are my parents. My dad's a dentist. My mom is the office manager. They just retired a couple of years ago, so they're enjoying retirement now, and very thankful to have the biggest cheerleaders ever. I did my AEGD at SIU and then the implant fellowship, and I had a full year of just placing and restoring implants. So that's where I developed that passion to be talking to you today. Did a lot of cool things in that implant fellowship. One of the things was using something called Navident that was able, if you see over here, I have a handpiece that is connected to some sensors, and then the patient has something on their head that is also connected to some sensors. And basically, I'm placing an implant looking at the CBCT directly in live time. And it basically has like a target that tells me exactly when to start drilling so that I know that I'm drilling in the right spot to place that implant. So just super cool things. Now Yomi is one that's like commonly used, but more in those practices that place, hundreds of implants and thousands of implants every year. I went on to private practice for a couple of years, and then I had the opportunity to be able to serve our nation's veterans at the St. Louis VA. It is a huge honor to do this every single day, and I'm very thankful to be able to take care of them and provide the best of care that I can. In 2023, I was selected by the ADA as one of the top 10 under 10 award winners. So top 10 dentists less than 10 years out of dental school. So that was a tremendous honor that I was thankful to accept alongside my parents. And if anyone ever has any questions or anything, I'm more than happy to answer them if you too are interested in nominating someone. And last but not least, I am editor-in-chief of Get Lit, which is a newsletter that goes out to over 23,000 dental professionals every single week. So we have one coming out tomorrow morning at 7 a.m. Eastern Standard Time. So if you're interested in signing up for that, feel free to use that QR code or go to ignitedds.com. So I would love to know what you guys would want to know. If there's anything specific, I do have the little chat box open. So I can, if you type anything, I can make sure that I hit that if possible, or if it's not already in there. So please, again, feel free to use that chat box or the Q&A, as Jessica has mentioned. So we all know how important a smile is, and I wanted to play a little game, which is a little bit hard to do when I don't have you in front of me, but you can kind of guess along and say it in your head and I'll help you out. But whose smile do we think this is? So a couple of seconds, but it's Tom Cruise. We all know that infamous midline shift rather. This is Angelina Jolie. Here is a tougher one. Kate Middleton, Usher. A lot of people know that infamous smile. Jennifer Aniston, George Clooney, and give you a couple seconds for this one, Anne Hathaway. Okay. So it's pretty simple to be able to, not see someone's entire face, but be able to just recognize them by their smile. So that really just goes to show, what a big role we have as a team, to be able to give someone a smile that is really them, that can, even define them to an extent. So then there's that one smile. And in my particular case, that was Minnie, who her smile changed my life and changed my pathway into dentistry. So at the time that this picture was taken, I was in dental school and I was really struggling with trying to figure out which pathway I wanted to take, where I wanted to use my dental skills, if I wanted to specialize and whatnot. And I was actually pretty dead set on doing endodontics, and which is funny because now I rarely even touch it. But I met her, and this is how I saw her. She presented 75 years old, had rheumatoid arthritis, so she couldn't clean her teeth, really struggled with holding a toothbrush in, was really struggling with, being able to smile properly, being able to chew properly. And it was the first case that I really got to do extractions. And she had 21 teeth left, and we had to extract all of them and do upper and lower dentures. And that was our ultimate game plan. And little by little, I extracted them. And because we had, certain protocols in dental school and whatnot, and made her dentures in my third year right before graduating, and was able to give her a smile that she really enjoyed and cherished. And I really cherished that relationship with her because not only did I get to know her very well throughout this time and help guide her through this, but then I got to see, what, maybe surgery is something that I'm really into. And I wanted to be able to give her, even the stability, which, as a dental student, didn't really have that opportunity to be able to place implants and whatnot. But I wanted to help give her that smile and that function, because as we know, and I went through it with a patient today, dentures are not a replacement for teeth. They're a replacement for no teeth. And they only give you about 25% of what your natural, dentition would give you. And so, a lot of patients, I had a patient today say, oh, Dr. Montine, like I was expecting it to be like in the commercials when I got these dentures. And he was a patient who had seen an outside provider, and I didn't do his dentures. And I told him, I'm like, sir, like those expectations, I would have loved to have discussed them with you prior, because we really need to set those expectations from the beginning and allow patients to understand where, what to expect with dentures. And every single person on the dental team has something to, a role to play in that, and explaining to the patient, how important it is to understand, hey, these dentures, are going to be the best that they can be. But again, there's nothing like your natural teeth. And, not to not give them something not to look forward to, but to help them really understand and be patient when it comes to developing that smile that we want to give them. So here's some, before and afters of Minnie, and we'll get back to her a little bit later. But 48% of adults aged 20 to 64 have a full set of permanent teeth, excluding third molars. Okay, so this is a really important statistic to think about, because this is all the opportunities that we have to take care of patients with some sort of prosthetic, whether it's a bridge, whether it's an implant, whether it's a partial, whether it's full dentures. So, if you're missing one tooth, it can really make a difference, as you already know, and we'll go into a little bit later. Fun fact, if you ever thought about it, think about what is the number one tooth to be replaced with an implant, or, to be lost in general. I'll give you a second for that one. It's your first molars, okay? And if you start looking at x-rays, you'll notice that first molars are usually the ones in older populations that have at least some sort of dental treatment on them, whether it's a filling, a root canal, a crown, or it's gone and now needs to be replaced somehow. There are an estimated 40 million Americans who are missing all of their teeth. That is a lot of Americans to be missing all of their teeth, and a lot of opportunity for us to be able to give them some function back, okay? So I will kind of introduce this way of talking to patients, now, so I don't forget you later with all that I have to say. But a way that I discuss the dentures, for instance, with patients are if I were to give a conventional denture a grade, I would give it an F. Okay. It's, not like your natural teeth. We try to make it as good as possible, obviously. And, we try to get that suction from the palate and everything. But most people, as we know, hate that lower denture. So now, I'm trying to put this into terms that the patient can understand more. So, I'm giving it an F, but how do we get to a higher grade? So if I'm able to place 2 implants on the lower in our 22, 27 positions, then I can raise that grade to a C. So I can give you some of that retention that you're looking for that unfortunately you just can't get from that lower denture. And now, if I want to be able to give you even a higher grade, I attach and add rather more implants. So that way you get more stability and you don't have to rely on your tissue so much, because with the natural denture and with even just the 2 implants, I still have to rely on your tissue and your ridge anatomy in order to create a good denture for you. But with adding more implants, now I don't have to think about that so much, and I can rely more on those implants. But something that the fellowship, as a side note, taught me was implants aren't for everyone. And a lot of people, nowadays they're taking courses to be able to place implants. And, I just really want, as general dentists, to, watch out for that and to make sure that you're getting the proper, thorough training, because I have seen how it can go really bad really fast. And it is really important to be able to have that comfort and know that you're doing, a slam dunk case, and you're able to know your limitations and refer out when needed. So course objectives today, we're talking about working as a team. So we want to understand the full spectrum of dental implant treatment. We want to enhance team collaboration and implant procedures. So we want to discuss staying current with advanced implant technologies and techniques. So we'll go through a lot of these things and different options that we can provide for patients, and how our team can work together to do so. So what is important for hygienists to know? So if we have, I'm hopeful that we have some hygienists that are listening in right now. And basically, some things are understanding implant anatomy, okay? So we want, as a hygienist, to help have a patient understand that implants differ from their natural teeth. There's no periodontal ligament. It's bone. You're not chewing on the implant the same way as you would for a general tooth. That's why the dentist needs to be able to check on how that tooth is, or how that implant is an occlusion, especially during the cleaning visits. I want my hygienist to understand, the different parts of an implant in order to recognize something. So whether it's a healing abutment, whether it's the implant itself, whether it's the final crown, they need to be able to understand that, and understand that osseointegration is critical for implant success. And I'll go into that a little bit later for you to understand when it's a good time to be touching that implant and when it's not a good time to be touching that implant. Proper maintenance and instrumentation. You want to make sure that you're using implant safe instruments. So I'll show you some examples of those, but you want to make sure that they're plastic, titanium, or specially coated, because you do not want to scratch that implant, because that leads to biofilm control, and how critical that is, because if you're scratching the implant and now you're able to accumulate more plaque on that implant, that's going to lead to peri-implantitis, which is failure of that implant over time. Monitoring and regular monitoring and documentation. Obviously, that's so important. I was always taught to write my notes like a lawyer is reading them. I document everything. Really big note that I write in every single thing is all of course, now I'm forgetting it. All materials, there we go, were used per manufacturer's instruction. Okay. I put that in every single note that I have because it's really important to show that, yeah, I read, all the IFUs, everything like that, and I know exactly how to use this material in the proper manner to be able to give a good result for that patient. You're looking for bleeding on probing, increased pocket depths. You're making sure that you're taking care of monitoring these implants so that, if something is starting to fail or something starts to look funky, maybe we can resolve that without getting so far as to losing that implant. I want my hygienist to be able to educate my patients. And, when it comes to flossing around that implant, using a water pick, using soft brushes, avoiding anything metal, because a lot of interproximal brushes have the metal on them. And we want to make sure that, again, that patient is not scratching that implant. Being able to detect complications early, I have alluded to that already, and know when to refer, when to pause, when to grab that patient, when to maybe, grab that dentist and say, hey, something looks funky here, and then kind of make that determination of maybe that patient needs to be sent to a specialist or, for further workup, or if something else needs to be done, like chlorhexidine, some sort of antibiotic, whatever it is. So what is important for assistants to know? So we want, again, assistants to be able to familiarize themselves with implant components and understand impression copings. I'll talk about that. Again, the healing abutments, cover screws, all of that stuff. Surgical and restorative setup, I'll touch upon that as well. Making sure that, we set up everything sterile, that everything is set up accurately, knowing drill sequences, knowing torque values, knowing when to change, the settings in our machines to be able to, when we're just drilling and when we're actually placing the implant, because those are very different settings and very different speeds. Assist with impressing, assist with scanning. So we'll talk a little bit about digital scans and, understanding the steps when it comes to delivery. So that also has to do with our instrument and implant care. Talking to the patient. So like I described earlier, it is very helpful when we're all on the same page and you start to say something to the patient, and now I come in as the dentist and say the same exact thing. That just shows the patient that we are a team, and it shows the patient that we know what we're talking about and we want, the best for them. So saying something like, about the dentures, hey, conventional denture, you'd give it an F. You could then go up to a C if we place 2 implants, stuff like that. Relying on tissues. Those are all good things that is okay for an assistant to speak about. It doesn't always have to be the doctor, but the doctor can follow up and, harp on those facts even more. So, as you guys know, patients hear one thing from the doctor and hear another thing from the assistant, even though they're both saying the same exact thing. And so, it's just like, for instance, I was talking yesterday with one of our hygienists. She was asking me, like, how do I get the patient to say that, they're having an issue with something? Because every time I'll ask them, hey, is there anything that, that's bothering you, anything I need to know about? And they say no. And then the second that you as the dentist walk in, they say, oh, yeah, this hurts, that hurts, blah, blah, blah. So the tip that I gave her was, and this goes for both hygienists and assistants, is saying, is there anything that I can bring to the doctor's attention before they come in the room so that, as they're reviewing the x-rays, they can look out for it and see how we can help you and have a treatment plan. And so now that patient knows, hey, like, I need to share this now because the dentist is going to find out, and that's going to let them, be able to answer my question more thoroughly. So just another, tip and trick. So patient communication and instructions, talking about post-op instructions, that's a huge thing. being able to triage a patient correctly, being able to help them out, if there's any issues, if they might have a question over the phone. Obviously, the dentist has a responsibility to speak to the patients as well, but any little help is really good. Again, when it comes to charting documentation, we're talking about documenting, reference numbers, lot numbers, torque values, healing times. All of those things are super important for us to be able to rely on our assistants to chart and document and scan into a patient's chart. Taking the proper x-rays. We'll talk about a very important x-ray that I would like you guys to start using if you don't already. Recognizing problems, watching for inflammation, patient complaints, looseness of that implant or implant crown, and support during complex procedures. We're a team and we need each other, and, rooting each other on is super important, and being able to work together to take care of these patients and have successful surgeries is always a great thing. So let's go on to what is important for the front office to know. So I would like my front office, and I like to refer, and I'll talk about it a little bit more later, but I try to have in the practice an implant coordinator. Okay, so that's the fancy term that I've come up with for that one, or I've heard it somewhere. But having an implant coordinator is important because we want someone in the office to be very comfortable with being able to discuss implants, discuss treatment plans, discuss finances with that particular patient, in order to, again, be able to kind of close the chapter of, all right, the patient came in, they're missing a tooth, or they're about to be missing a tooth. The assistant has talked to them. Now the dentist has talked to them. And now that implant coordinator is going to wrap everything up and put a bow on it and move forward with treatment. So we want that implant coordinator to be confident in communicating about dental implants, be able to explain the treatment, be able to explain the sequence of treatment. So the consultation, then the surgery, then healing, and then the restoration, so that, a patient doesn't think, oh, I paid, let's say $2,500, and now that's the whole thing. It's like, no, $2,500 was just the implant itself. Now we need to add in the restoration. And understanding that implants are not, a same day procedure. You're not necessarily always going to have a tooth immediately there. And most of the time we only know, what's going to happen the day of the procedure. Being able to schedule properly is very important, with, being able to keep healing time in mind. I will talk about the way that I like to schedule appointments between the surgery day, and then 1 month later, and then 3 months later, 3 to 4 months later, depending on how that implant was placed. Like I said, treatment planning and financial discussions, understanding basic coding. So I know those implant codes like the back of my hand, 6010, 7953, 6104s, and, every, code that you can think of that has to do with an implant. I almost know all of them. So you really want to have someone who's comfortable with that as well, and knowing that, things are going to get billed out correctly, and helping the patient also understand that typically implants are not something that are covered by dental insurances, and coming up with, a plan of paying for those. Pre-op and post-op instructions, our front desk needs to be comfortable with that too, because they are the ones answering the phone. Terminology familiarity, obviously can't stress that one enough, being able to explain the different parts, but in a sense, for helping the patient understand, okay, yeah, it is time for me to uncover my implants. And then after the uncovery, I have to wait 2 weeks, and then I can get scanned for or impressed for a restoration. Efficient case coordination. This involves, with the lab, with a specialist, if the dentist is not placing the implants, with the dentist themselves, with the assistants, with the hygienist. So all of that is very important. And last but not least, empathy and trust building. All of us, the front desk, you're the front line, okay? And so when that patient calls, you need to be empathetic, and understand, okay, this is the phase that they're going through right now. This is probably how they're feeling. How can I help? How can I help build that trust? How can I de-escalate any concerns that that patient might have. So sometimes I'll say veteran, by the way, just because I'm used to talking about veterans as my patients. So please excuse me ahead of time if that slips out. So let's talk about options for our patients. So I'm going to go into all of these things, but we're talking about single tooth, so immediate versus delayed versus mini implants. We're talking about implant supported fixed partial dentures, which are also called bridges. So that's an implant to an implant, because we never, ever, ever want to place an implant to a natural tooth. Like I said earlier, a natural tooth has a periodontal ligament, and then that dental implant is integrated into the bone. That's what osseointegration means. And so it's like a seesaw effect. If you have a PDL and that tooth is allowed to move up and down, but you have something that's stuck in bone that's not moving, and we're like this, then something is going to break. Okay. So that is why we do not want an implant to a natural tooth. Implant supported removable partial dentures. So I'll go through a case of where I did that for a patient, and you can understand how maybe, not putting a bunch of implants, but maybe using already placed implants or something like that, or just placing, one or two in certain areas can help, eliminate clasps and whatnot for a patient and create more stability for that partial. Then full arch prostheses. So we'll go into tissue supported implant retained. So that's what I was talking about with your locator overdenture. But of course, the more implants you place, the less you need to rely on that tissue. And then implant supported implant retained, which are examples are bar overdentures, Conus, Spark Erosion, Locator FTX, and hybrids. Okay, so a lot to go through, like I said, but we have another hour to get through it all. So single tooth, immediate delayed versus mini. So imagine seeing this patient on Monday morning or Wednesday morning, so tomorrow. This was a patient. He is, his name is Bolingo, and he is a massive gorilla, as you can see. And he's over at Busch Gardens in Tampa, Florida. So the gentleman that's wearing the blue scrubs on the right-hand side his name is Dr. William Geyer. And I got to know him when I was in dental school. I actually saw him on TV on a show called Wildlife Docs. And they were talking about how dentists come in and treat the animals too. And I looked him up, and I got to go over to the Busch Gardens with him and work on a couple of animals, like a red kangaroo and a lesser bush baby that literally fits in the palm of your hand. But he had a patient that came in, well, hopefully not came in, I hope he wasn't awake. But his name's Bolingo, and unfortunately, Bolingo had a canine that needed to come out. Okay. So that tooth came out, and you can see that's a pretty massive tooth. So my question to you guys is, hopefully Bolingo is not in your office and a human is, but if we were in this situation where we had to take out a super important tooth, or any tooth, because every tooth is important in its own way, what are we going to do? Are we going to place bone? Are we going to extract and immediately place an implant? Are we going to delay placement? These are all questions that we need to think about before we even extract that tooth, okay? So in my opinion, I do feel like standard of care should be to place bone in every single extraction site, because whether you're going to place an implant, whether you're going to do a bridge, whether you're going to do a partial, a denture, whatever it might be, I do feel that bone is never going to hurt because you lose 30% of bone when a tooth is extracted. And so you really want to be able to keep as much as you can of that ridge width and that anatomy that's going to allow for proper hygiene later on, and potentially even proper placement of a dental implant. So I am one of those dentists that is not the biggest fan of extraction immediate placement due to, the density of that bone, and making sure that, because you do have a higher failure when that happens. But, to each their own. Of course, there are certain situations where it is not a bad choice or anything like that. So, and it's not that, I'm never going to extract and immediately place. But just something to think about when you're deciding. If you're someone who feels that, maybe that tooth, there was a lot of infection around that tooth, maybe you should wait and delay placement to make sure that the body takes care of everything. If you're someone who isn't, doesn't think that patient's that cooperative, or maybe there's financial issues and you need to kind of phase it out a little bit, it's a good way of phasing things out. So just some things that we can share with patients. Again, a lot of patients are going to ask us, no matter dentist, hygienist, front office, or assistant, how quickly is this space going to close? So it takes 38 days for soft tissue coverage. So that's about 5 weeks. Okay. So for that area, for that hole to close, it's about 5 weeks for it to kind of start to feel a little bit like you're not, tempted to put your tongue there anymore. Okay. 2/3 of bone loss occurs within the first 3 months. So why is that important? It's important because it shows, again, if you're losing 2/3 of bone, but you don't have any bone in that socket, now, really quickly, you should have put that bone from the beginning so that, those 3 months don't pass by. And now it's very hard for me to go back and try to build that bone. Okay. You lose overall 50% of ridge width more in the mandible than the maxilla. Okay. So just another reason why being able to explain to a patient, it is important to be able to extract and place bone, even if we don't know what we're going to do, if you don't know what your finances are, whatever it is, you're setting yourself up for success in the future instead of failure, or at least a higher chance of success, because of course every patient is different. And then major changes in an extraction site occur during the first year after tooth extraction. Okay, so after about that first year, then we're kind of settled at where we are, and then we kind of go from there to understand, especially if we do have a patient that comes in after a year after extracting the tooth, now we kind of know this is what it's going to look like. I'm not worried that something's going to change a big chunk, so I know, okay, now I can start planning my implant if I wasn't part of the pre-op. Okay. So to bone graft or not to bone graft, like I answered before, I do feel like grafting should be a standard of care, just to be able to save that site as much as possible. So just some examples, again, it is very hard to build bone. It is very hard to build bone horizontally. If you can have as much bone as possible beforehand, make it happen. So Belingo, unfortunately, was not able to find an implant that was long enough to take care of his canine, but he still has 3 more and he's doing just fine. So nothing to worry about for him, but in case you were wondering. So I keep talking about implants, but I haven't really gotten into what is an implant. So an implant basically is 4 parts, but typically we only talk about 3 parts with our patients. So we have the implant itself, which is the screw or post. I always try to use the word post because screw just sounds kind of not that great of a word. And you don't want people to think you're going at Home Depot or Lowe's to pick out a screw for them. So the implant is the screw. It is the screw itself, so the post itself that goes into the bone. And I always try to educate the patient because I know they're always like, "Oh, well, my implant," and it's like, but that they're talking about the whole implant crown and stuff like that. And I try to help, because they're like, "My implant's loose." I get that. I get an alert from the front desk, like, Dr. Mentini, the implant's loose. And I'm like, no, the implant's not loose. The crown is loose. And so, helping educate those patients so that you can make a better determination. And also your own team being able to kind of sense, hey, this is what kind of looks loose. I don't know, after taking the x-ray, the implant looks okay, is always very helpful. So that, maybe you can start to calm that patient down a little bit. So we have our implant, we have our abutment. So I refer to the abutment as the connecting piece between the crown, which is what you see with your own eyes, and the implant itself, which is in the bone and acts as the root that you used to have for that tooth. And I don't really talk about the retaining screw. That's just something for us to know, but that's the screw, that goes into the abutment and helps keep that in, and then your crown goes over it. So we have mini implants, as you can see on the left-hand side. We have our bone leveled, tapered. We have tissue leveled. There's just so many different types of implants out there. There's ones with very aggressive threads. There's ones that are super wide, super long. You have now the zygomatic implants, and just so many different things that we're able to do with these titanium implants in order to help our patients, or zirconia. There's a lot of different systems out there. Here's just some to name a few. There's Nobel Biocare, Dentsply Sirona, which is Astra, BioHorizons, Straumann, Zimmer Biomet, Southern. I mean, there's just so many implant systems for that people are working with, but these are some of the big ones that people are using out in the world. You can ask me later what my favorite is. But I will say each of them has their own little superpowers. So now trying, to explain to a patient, and also, for yourself, of understanding the difference between a cover screw and a healing abutment. Okay. So a cover screw is, you place the implant. Now you have to put the screw that goes over the implant, but flush with the top platform of that implant. And then you put the tissue over that, and now you can't see that implant. Okay. This is typically, where I'm at when I'm placing an implant, because I want to try and make sure that I give that implant every single chance that I can to be successful. Sometimes a surgeon will place the implant, place that cover screw, close it up, and then after 3 to 4 months, or whatever the time is that they want to go in and uncover that implant, they're going to make a little incision. They're going to see that cover screw, unscrew it, and then put in the healing abutment. So the healing abutment is what gives the dentist, the restorative dentist, access to that implant in order to take an impression and put a crown over it. Okay. So, very important to always tell the patient that if they lose the healing abutment, they immediately need to call the surgeon or whomever placed that implant, unless you at your office are comfortable as the dentist with uncovering that implant if they have the healing abutment. I still would let the surgeon do it, because there might be like bone in the way, and that's why that healing abutment didn't seat all the way, or whatever it might be. So but that's just my 2 cents. But it's important to be able to share that with the patient, because if that healing abutment comes off and they come in even the next day, that hole is closed. It's a very small hole. The tissue collapses very quickly. And then now you have to do another surgery and delay treatment if, it's time to take an impression. Okay. I've had quite a number of people that come in and are very upset, from, the outside or whatever, that they've had an implant placed by the specialist. And then now they're coming in for that, because obviously we can't, place every single implant that comes in. But they come in and they have that healing abutment placed, and then that healing abutment comes out and they're expecting me to take the impression. And I'm like, sorry, chief, like I can't make that happen because I don't have access to it. And now, you need to come back, wait 2 weeks for the tissue to heal so we can get a nice impression of everything. So please stress that to your patients, and how important it is to come back as soon as humanly possible if that comes out. So there's also custom healing abutments. So in the picture before, you saw a standard healing abutment. That's just something that the manufacturer will send to you after you've ordered it. A custom healing abutment is basically being able to put, what looks like the tooth already in that implant right after you've placed it. Okay. Sometimes people will do it later on to try and mold the tissue, but usually it's you've placed it. Now you're putting this custom healing abutment that now it'll let you mold the tissue as everything is healing, so that you create a nice emergence profile, so that that tooth will look as natural as possible, or as natural as it can when you put in the final restoration. So in this situation, I had placed a Straumann VLX implant, which you can't see in the picture, but I placed that implant and I immediately did a custom healing abutment. The key things for that is that you have to trust the patient that they're not going to chew on that implant in any which way. And if you've noticed, that implant, that healing abutment is very, very short. And it's also it's a lot more buccal. So it's very short because I do not want that patient to bite on that implant healing abutment in any which way whatsoever, in any excursive movements, because I don't want them to be putting pressure on that implant while they're healing. And then later on, we're able to create a much, like I said, more natural emergence profile in papilla. So this patient was one that I did in my fellowship. I was not able to do the final restoration, which you see in that lower picture. But, I personally probably would have chosen a little bit of a different shade, but to each their own. Beauty is in the eye of the beholder. But that is how, we were able to create, a final restoration from that custom healing abutment that I had done. Crown down mentality. So this is more for the dentists and the assistants, in that we're always trying to place a dental implant with the end goal in mind, which is that crown. So you're trying to place it knowing that, okay, once I put that implant in there and now I'm putting a crown, I want the all that pressure that's going to go into that implant to go straight down the center of that implant instead of on the side, because remember, we don't have that PDL. So now if we have a tooth that is in the bone, so that the implant crown and implant that are in the bone, I don't want any forces that are going on the sides of that implant that are going to make it start rocking and then eventually fail. I want that force of occlusion to go straight down that implant, so all the pressure is going in it and not being dispersed on the sides, and it will start moving back and forth and fail. So again, here are our different parts: our crown, our abutment, and our screw. And I want to place that implant with my crown down mentality to be able to restore it so that I am in the central groove or wherever it may be. I'm not, sitting on the margin or a marginal ridge or something like that that's going to end up making that implant fail over time. So let's talk about our timeline, okay? So, and oh, sorry, when I said that, that's also something for the assistants to be attentive to. It's because I'll show you in a little bit what I like to do with my assistant when I'm placing an implant. I want you guys to be my second set of eyes because I, need you to help me. And with that, if you're understanding, that I need to place, for a front tooth, I need that implant, access hold to come out of the cingulum. For a posterior tooth, I want it to come out, straight from the center. Then your set of eyes are also going to be looking to make sure that I'm lining up with other central grooves, that I'm, being able to place that implant with the ability to restore it. So let's go into our timeline. So stage A, this is how I have, the whole office thinking about everything. So we're evaluating the patients, basically our consult, right? We're evaluating the patient, taking diagnostic casts and a CBCT, okay? Stage B, we're going through our treatment plan presentation. Oops, sorry. Got a little excited there. Treatment plan presentation and payment. That's with our implant coordinator, the payment part and everything, and guide fabrication. Then we have our surgery day where we're either going to place, we place the implant hopefully, and then we place either the cover screw or the healing abutment. We have a post-op 1 week later, a PA that we take at a month, CBCT that we take at, let's say, 3 months if that's the protocol we're following. Uncovery with 2 week healing. Then we take our impression, analog or digital, and deliver our prosthesis. So let's go into each one of these. So stage A, we're evaluating the patient, taking diagnostic casts in our CBCT. We're looking at medical and dental history. We're making sure they're not smoking, okay? You have an 85% increased chance of failure of a dental implant when smoking. Excessive sugar, if we have an uncontrolled diabetic. A1C over 7.0 is a big red flag. Excessive alcohol, and then no bisphosphonates, okay? I had a very unfortunate situation in private practice where I had a patient that she had the check ready to go. It was a heftier check. I had the goal was to place a couple of implants on the lower to help her maintain a lower denture. And I just kept asking her every which way, to make sure that she, was, in proper health and whatnot. And, I asked, do you take any bisphosphonates? And she said no. And, I had noticed in her chart, it said osteoporosis. And so I was just really trying. And this is again where, all of us as a team come together, maybe you'll remember this question if I don't remember it and, whatnot. But and when you're getting to get to, know the patient, it's another way of being able to find these red flags. But, she said, or I said, is there anything that you take for bone growth? And she said, no. And I said, okay, is there anything that is injected into you once a year? And she's like, oh yeah, I have, this thing that's injected, to help my bone. And I'm like, uh-huh, like what we just discussed. Okay. So she was on reclast. Reclast has a very long half-life. And so I called up one of the oral surgeons that I know and I said, hey, would you do it? And they're like, nope. And I said, all right, if you're not going to do it, I'm not going to do it. So I unfortunately had to pass that check right back to her and say, sorry, ma'am, but this isn't going to happen. So going into them a little bit more with some fancy pictures. So we have, our smoking, making sure they don't have periodontal disease, because like we know, a lot of people, they think, oh, I'm going to get implants. Now I don't need to brush my, teeth anymore, whatever it is, I'm good, because nothing's ever going to happen to those implants. And that is very wrong. So if they can't take care of their natural teeth, they're probably not going to take care of those implants very well. And another thing to take into consideration when someone has periodontal disease, they've lost a lot of bone. And so now you're going to have to place that implant even lower. And then now you're going to have a super long crown. And that crown to implant ratio is equal or more crown than implant. And that's another recipe for disaster. So think about all of these things, because you want to, again, set up that patient for success, because you don't want a headache. You don't want to hate seeing that patient's name on the schedule. Here's some bisphosphonates, uncontrolled blood pressure. So again, if someone has, high blood pressure, now, we're dealing with more issues that can lead to implant failure. Uncontrolled diabetes, the alcohol, again, that also has to do with sugar and whatnot. Making sure that they, all of their medication in whatever way they like to say it. I have this patient that listed ibuprofen and Tylenol. So, sometimes you need a translator for some of these, but I always get a little laugh out of them. Out of the spellings. Clinical findings. Again, write your notes like a lawyer is reading them. You want to make sure that you have written any single little, filling that's on there, any cavity that's, on the teeth, because if that filling all of a sudden disappeared, well, doctor, it was your fault. You did it to me during surgery. Nope, I didn't. I, properly have, everything documented, x-rays, everything like that, to show that I knew what was going on and I did not cause whatever a problem or whatever it may be. Periodontal charting completed, again, related to that periodontal disease, oral cancer screening, TMJ evaluation, no clicking, popping, discomfort upon opening and closing present, because you don't want someone to have, their mouth super, open for a really long time. And while you're trying to place that implant, you're trying to get in there, fit the drill, blah, blah, blah. And now all of a sudden they're getting these TMJ issues, but you didn't document that they already had them, beforehand. Load test, if you're comfortable with that and, have had the training on all that to, check the jaw and make sure that nothing is going to stress it out more than it needs to be. Maximum opening. This is very important to record maximum opening, because if you're trying to get into a second molar to place an implant over there, which, side note, second molars only provide 5% of chewing forces. So they're not as important. People are going to be okay with that first molar occlusion. All right. So second molars, you're trying to get in there with your instrument, you have a super long drill, all of that, and your handpiece, and they only open like this much, it's not going to happen. So either explain that to the patient or refer out unless someone else explain it to them. Okay. Interocclusal space deficient. Super important when it comes to your restoration. Every single restoration has a certain minimum amount. And I believe I go into that. Maybe not. Okay. So with the interocclusal space, if you're doing cement retained, you need at least 7 millimeters of interocclusal space. So that goes from the crest of the bone down to the opposing tooth. Okay. You need more space for the parts that are there. Screw retained or screwmentable implant crowns, they can be 4 millimeters. Okay. So make sure that you have at least 4 millimeters of space for those two, or 7 millimeters for cement retained, in order to have enough space for all the parts and pieces that you need to be able to place a crown. If it's less than that, it's going to fail. There's just no space for a crown. Okay. Extraoral and intraoral photographs. This is very important for you to have a nice camera to be able to document everything, not necessarily for giving presentations like me, but being able to explain to your patients, being able to showcase your cases, so that, you can be able to have other patients sign up for treatment plans. Okay, so this is my camera. And if you have any questions, I did purchase it through PhotoMed, which is a great company out in Canoga Park, California, that really helps, with putting the cameras together and making them as friendly as humanly possible for you and your team. So I do like to train my dental assistants on how to take pictures. And so you'll see pictures that went well and one that didn't go so well. But these are some really key pictures for you to be able to have for, even every single patient if possible. So we have our full face profile smile. Now you see why I took these pictures for this implant patient. Full smile, rest position. So this is the one where you have the patient lick their lips and say Emma, and just have them relaxed like that. That shows you how much display of tooth structure there is, because the less tooth structure you see, the older you look. So check that out if you weren't familiar with that. Front retracted, teeth together, front retracted, teeth apart. Right lateral retracted, teeth together, left lateral retracted, teeth together, upper occlusal. Here's our little hiccup, lower occlusal. So we got much better at that over time. And any additional pictures that you might need. So here I really wanted to see that, knife edge of where those implants needed to be placed, because I really needed to build up that area with bone. So now we've taken our extraoral and intraoral photographs, and now we're going to take our impressions. So analog or digital. This was an impression I took I think I was in my residency, and I just really loved, the the folds in that vestibule and the frenums. So I had to take a picture of it. But we have our alginate impressions, PVS impressions. These are actually my teeth, and my dad took these impressions. This is another good one for us to be able to share with the lab, because they could pour it up multiple times. And then we have our digital impressions. Okay, so this is actually, these are my teeth again. If you haven't noticed anything different about my teeth, I have 3 premolars. One of them on each side on the upper is actually a dental implant. A long story short, I had a pretty deep class 2, Div 2, and my orthodontist brought my upper teeth forward in order to create more space for my lower jaw to develop and not have sleep apnea issues. And that left 2 spaces in the back for 2 that actually happen to be perfect sizes for 2 little premolars. So I have 3 premolars, but yeah. Very good for patient education to be able to show them these digital impressions. So we take our bite registration, centric relation, Facebook record, especially if we're doing some big cases. CBCT, we take that and interpret it. Why is CBCT important? It is now the standard of care. If you are still doing, placing implants with a PA and a pano, I, highly suggest you invest in the CBCT. It will give us, a view of where the sinus is, view of how much buccal bone we have, palatal bone we have, and where the other teeth are. There are so many things to think about when it comes to placing an implant and watching out for vital structures, where the nerves are and whatnot, that it's really important to have that CBCT, check out lingual concavities, anything like that where, stuff can go wrong. Okay. So this is where I like to use my assistant. Here I was placing an implant, and now I start walking around the patient, and my assistant's holding everything together, and then we actually take turns walking around the patient to see exactly, like, am I angled a little bit too far, lingually, facially, mesially, distally. I want to make sure that I have two sets of eyes that are looking at this and walking around the patient, literally, to be sure that, hey, I have the perfect angle as good as I can for this dental implant. So here it was after I placed that implant and stayed, sufficiently away from the sinus, stayed sufficiently away from the, to get 2 millimeters of buccal bone. That is not a void, by the way. So yeah. And this is what can go wrong if you don't take implant or take a CBCT. Okay. So this patient had an implant placed, but then, once that, you look straight on from at the picture, at the x-ray, everything looks great. And then you take a look from the side with that CBCT and uh-oh. So again, CBCT is your friend. So now we've taken our CBCT, we're talking about finances and timeline. And now that's our stage B, where we have our implant coordinator come in. And, I want you guys to be able to understand, how to answer these questions properly. So patients ask, how will a dental implant benefit my oral health? What happens if a missing tooth is not replaced? What is the dentist's experience with implants? These are a lot of questions that come up. So here's a little script that you, as whether, front desk, hygienist or dental assistant, can use to kind of, if it's the proper situation. So make sure, you're not, hyping up someone for an implant and they have all of the red flags. But here's something that you can use to help out. So Mrs. Jones, I see that you have a tooth missing on your lower left, and I'm concerned since a single missing tooth often leads to more missing teeth, like a domino effect. I love using that term. We love helping our patients with missing teeth restore their dental health with a dental implant. Our doctor has advanced training in providing dental implants, and we can do that right here in our office. As you guys know, patients love to stay in the same office. I'd like the doctor to look and see if you are a good candidate for a dental implant. Does that sound good to you? That's a great way for our team to be able to introduce the concept of a dental implant and see, kind of what that patient might be interested in. Okay. So, gone through all of this, patient says yes, and now we're on to fabricating a guide. So we're taking our impressions that we discussed earlier. There's different types of guides. It depends if you're doing a fully guided surgery, if you're, stacking guides, if you're doing a pilot guide. That's for another day because, again, I could talk forever about implants. So now we come up to surgery day. And organization is key. Okay. It has to be a sterile environment. We have to have everything out. We can't keep going in and out of the operatory. We can't forget stuff. Make sure that you have a checklist and that you're ready to go for the implant place or surgery. So we need our lab case. We need the parts and pieces. We need our surgical guides. We need our health history. We need consent forms. A little tip is to tell your patient beforehand, to give the patient the prescriptions, a couple days beforehand, so that maybe they can go and pick up everything before, so they're not, getting the implant placed and then, trying to rush off to the pharmacy. Having them take, 600 to 800 milligrams of ibuprofen about an hour prior to the appointment is a good idea, because then that's already kind of getting in their system. And you always want to make sure that patient gets ahead of the pain, so that, they're not waiting. And this goes for, not just implants, obviously, this goes for extractions as well. Get them ahead of the pain, because, that medication is never going to work fast enough if they wait until the last minute. So now we're talking about the setup. Like I said, remember, this is surgery. I'm just going to list these. These are just a lot of things that, of course, every single doctor is different, but good things for you to be able to have ready and set up when it comes to placing dental implants. So let me get to the end, and I'll give you guys a quick second to take a screenshot. Because, yeah, you don't want to forget the implants, or else you're going to look like Macaulay Culkin over here. So these are just, different setups of everything. This is one type of implant kit. Here's another implant kit. So again, each manufacturer is going to have, of an implant system is going to have their own surgical kit, and they'll teach you exactly how to place stuff, how far to go. You want to make sure you're familiar with that implant placement procedure. So you're going to be, doing a pilot drill so you get your initial direction and everything. I like to take, an x-ray at that point. Then you're going to start drilling and making that hole as big as it needs to be for the implant size that's chosen to be placed properly. Okay. You're drilling pretty quickly, at a pretty fast speed. I'm talking about you're only in the mouth about 10 seconds or so. You definitely need irrigation when you're making those initial osteotomy drills. And then when you place the implant itself, it is so slow that you're placing it just very, very, very slow until you get to where you need to be. So again, implants inserted into the bone. Now you've placed a cover screw over it and allowed it to integrate into the bone. And then you'll uncover it, do your healing abutment, take an impression, go on and place your final abutment with that crown over it. Here's an example of my notes. So if you have anything, I'll have my, any questions and you want to get a copy of that, I'll have my info at the end, and you can email me and I can send you my templates for implant placement, post-op, stuff like that. So immediate post-operative care. So these are very important for every single person on the team. Minimize contact with the implant. The implant is stable upon placement, but however, between week 4 and 6, the implant loses some of its stability, but will regain it after week 6. Okay, this is very, very, very important because if you noticed, I have the patient come in after a week and I'm just checking everything, making sure all looks good. The sutures are good if they're still in there or whatnot. And then I have them come in at a month. So that's week 4. At week 4, I'm taking a PA to make sure all looks good, but I'm reminding them, do not touch this implant with whatever it is. Please avoid this implant to save your life, because at week 4 and week 6, as you'll see with this bell curve, give me a second, here we go. You have our primary stability where when we first place that implant, so that's in the bone that you started off with, and then everything's nice and stable. You get that, torque of whatever, 45, whatever it is. And then now at week 4, that stability starts to dip because the new bone is coming in. And between week 4 and week 6, that new bone's coming in, and then it starts to get its stability back up again. Okay. So it is very important that hygienists do not clean around the implant between week 4 and week 6. Do not touch that implant. Do not just check it. Do not nothing, because even just touching that healing abutment gives you a higher chance of that implant to fail. Even better, don't even schedule the patient for the 3-month time around the implant placement. So if you can take care of cleaning their teeth before they get the implant placed, and then, bringing them back in 6 months later, because, like I said, at that point, hopefully they don't have horrible, perio disease or anything that you're placing that implant in. But even if it's your 4-month mark, it's a lot safer to be able to clean those teeth then, instead of doing it in the time that it's osseointegrating. And I did skip over here. I said the patient may want to limit foods to soft items and chew on the other side for the 10 to 12 weeks of integration. Okay. So here was that slide that I referred to earlier of using implant safe instruments. So no metal scalers, plastic, titanium, or specially coated instruments only. Here's some examples from different manufacturers. And avoid scratching the implant or roughening it because that promotes plaque accumulation, like I mentioned. Woo, I gotta go quickly. So post-operative medication, Tylenol and ibuprofen are your best friends. As we know, combination therapy of them works better than an opioid. So now time to restore. I'm really going to go a lot faster through this. Sorry, guys. Parts needed, impression coping. We can have open trade versus closed trade. We have a scan body that's used for digital scanning. A lot of people will use closed tray if they're doing analog impressions because it's a lot faster to use, though open tray is technically more accurate. If you're doing a scan body, always try to point the bevel. So as you can see, there's a bevel on the front of that towards the buccal. It's easier for the scanner to pick up. So as you can see, here's some pointed towards the buccal. And then you have your impression analog. Sometimes the lab wants that. Usually they don't want it for digital ones because they're able to digitally plan it all. But your analog is basically your replica of that implant so that the lab can pour up the model. Like I said, wait at least 2 weeks after an uncovery to take the impression. So now everything is, the tissue is nice and happy. Big thing to know. Vertical bite wings. Try and always take a vertical bite wing for impression coping seating purposes, custom abutment seating, and cement removal. Because if you're taking a PA, so if this is your implant and you're taking a PA from an angle, you're not necessarily going to see where that implant platform and the crown meet. And so you're going to miss some of that cement if you're doing a cement retained crown. And you won't necessarily see if anything is completely flush if you're checking on the seating, okay? But if you do a vertical bite wing, so now you can see a lot more, you can even see the screw and you're taking it straight on, you're a lot better able to see that everything is the way that you want it to be, okay? I won't really go into this just for the sake of time, but your open impression tray. So again, you're just putting a hole into that implant or into that custom tray and making sure the patient stays open really big. Closed impression, you don't need to make that hole. Then always, I like to use medium body for this and a 5-minute setting time because it's a lot more rigid. If you're using light body, it still kind of flows every which way and isn't as rigid when you're sending it out. Never torque anything except for the final screw. So there is a lab screw and there's a final screw. The lab screw is the one that the lab is using to take, the crown in and out to check everything. Your final screw is something that is completely untouched and you should be using that to deliver your crown. Have that discussion with your lab. Here you can see the difference. The final screw is usually gold and you can see there's a bunch of gunk on the silver one. And that is because that was the lab screw, okay? So some more pictures of that. So cement retained implant supported FPD. This is just an example of a case I did with an analog implant impression. Patient came in with a retainer that was replacing some teeth. He had these implants placed by an oral surgeon 2 or 3 years prior, had never had them restored. As you can see, they're not ideally placed, but thankfully he does not have a high smile line. So this is how they look. This is, at that time, I did not have a digital scanner, so I did everything analog, took out those healing abutments, placed my impression copings, have my medium body, take my impression, take my bite, my opposing, and then send my shade to the lab. And then delivery, this is what it looked like a big blob, more or less, except when you actually see it, you're like, oh, okay. So custom abutments, because we had to do cement retained because of where the access holes were coming out of. That was a verification jig to make sure the custom abutments were seated properly. Here I'm putting in the final screw. I torque it down, cover up with Teflon tape, clean the inside of my implant bridge with Ivoclean because it was ceramic, ceramic zirconia. Here's my Teflon tape. Don't say plumber's tape in front of the patient. And here it is. This man literally stopped at every single operatory in the office and went to every single patient and said, look at my smile, look at my smile. Obviously, if you lift up the lip, you see a big difference, but you can't see it when he smiles, and he was ecstatic. And we reviewed obviously hygiene and all of that, and he is one happy camper. Then we have our digital implant impression. This was a patient in my fellowship who she had this tooth. We were doing a study using Southern Promax implants for extraction immediate placement in a molar. I don't know that I'd have the guts to do this on my own and not in the fellowship with such a big infection, but 66-year-old female, class 3 mobility and foul odor on number 30, period depths between 6 and 11, root was fractured. Take it out, looks like this. Place a ginormous implant, 8x9. But that was the like I said, superpower of that implant system. Take a scan of it so that we can do a provisional. This was part of the protocol of that study, but we did a peak abutment temporarily and then had the patient come back in a week to do a provisional. So a custom healing abutment. This is how that implant looked. Mind you, all of that area is clean. That is not infection in there. But you can see it's a very big implant. And here's just another view of an implant supported bridge that I was taking an impression of. So you can see how the bevel goes toward the buccal. When you scan for an implant, you're going to scan the opposing arch. You're going to remove the healing abutment so you can get the way that the tissues are contoured and take a scan of that. Then you're going, this is just another like a flipped view of that. So you can see it from the inside. It's really cool how everything gets stitched together. And then you're going to do a bite registration and put in your scan bodies, really get a good scan of all of them. Usually the scanner is going to give you a little green check mark so you know you're doing well. And then now you have all the scans to send to the lab. So now let's get into some cases that go into the different options. So single tooth, well, we read all of those before, okay? So anterior single tooth, this was a patient who came in to my private practice. The owner doc really wanted me to, actually no, it wasn't it was one of the other doctors, wanted me to place an implant at number 7 because the patient just really, really wanted it. I obviously that's, to me, I'm just seeing, red flag, traumatic occlusion, not really taking great care of his teeth, but he really wanted it. And at that time, with patient education and whatnot, I told him, I'm like, he needed some other stuff, to happen. He was getting some more crowns and working with the bite a little bit. So I said, okay, let's place the implant. I was okay with being the surgeon, and then they did the restoration and everything. So here's our spot. You can see I actually had a pretty thick ridge. Couldn't place an implant further back over there because the sinus was very far down and he was not interested in any sinus lifts or anything like that. This is another reason why I was okay with placing it, because of that nice, beautiful ridge. Place the implant, again, ligate everything, because God forbid you lose and have to go fishing. Then I have my pilot drilled, and now at this point, I went to the width that I needed to for the dental implant. I'm checking every which way. I now place the implant. I'm making sure that I'm far enough away from the neighboring roots. I have enough, 2 millimeters of buccal bone or facial bone in this situation. Now I'm checking again with the mounting piece to make sure it all looks good. I'm out of the cingulum. I couldn't have asked for anything more. In hindsight, sure, I could have placed a little bit of bone in that little buccal dip that you see over there. But I still had plenty of bone in that area. Sutured it. Of course, patient was not very compliant and came back the next day. The sutures fell out. I'm like, did you play with it with your tongue? Yes, I did. I'm like, did we not discuss that? Yes, we did. Okay. So that was one example. Now we go into implant supported bridges. So we already discussed, not doing tooth to implant, but here you can also see you can have even 3 different implant supported bridges, and that's really the most ideal situation instead of a hybrid or anything like that to restore a mouth. But this patient came in, this was the owner doc's patient, and she didn't want to wear a partial. She didn't want any of the clasps. She had tried a partial, hated it. I look at that interocclusal space. I was really nervous, but I talked to the lab and we said, okay, we can kind of fudge it aesthetically to make it look really nice, but still have enough of that, I barely have that 4 millimeters to make it happen so that I can have enough space for the parts. So I went in, I placed the implants. I like to place them 2 millimeters below the crest so that I get a nicer emergence profile and whatnot. And here you can see perfectly placed in the cingulum, perfectly placed down, not, right smack in the connecting point of the bridge. I'm in the central groove. Again, couldn't have asked for anything more with this patient. We were able to fudge it, aesthetically to make it look really pretty, and that patient was ecstatic. Implant supported removable partial dentures, go into that option. So we have our implant supported partial. This is the one that I was talking about, where we can eliminate the clasps and be able to use some implants, and not so many implants, but maybe like we said, 1 to 2 implants, depending on what that patient can invest in order to have it clip into that implant, into the partial. So this patient came in, was also one of the doctor's patients. As you can see, I was the surgeon of the group. And wow, just wow. Okay. So the question was for me to place an implant in that anterior region. I said, how about no? Because this is how all of it looked. And he already had a couple of implants that were restored. He had a couple of implants that nothing was, he had, had those healing abutments in there for a couple of years. And I said, okay, what options do we have? And so, I discussed taking everything out, including the implants, major surgery. It was going to cost like $30,000. The patient was like, no, I really don't want to do that. Then we talked about doing Conus, and which I'll talk about a little bit later, but I was able to plan everything out with the lab. And if we placed 2 implants on that upper right-hand side, then I was able to have enough, the degrees of taper weren't too bad where I can do a Conus implant denture. And that was about $20,000-ish. And he was like, yeah, still a little bit too much. And then we came up with the idea, so you got to be really creative with this, but to do an implant supported partial where basically I took out these teeth that you see X'd out. I used his implants still, the implant crowns, because he already invested all that money in them. And so I said, let's, keep using that, use that as if they were natural teeth, but now hook on the partial into the implants and use those implants, take out those healing abutments, and do them like Zest locators. Okay. So we had one Zest locator and then a custom locator. And that was what the partial looked like. He was wearing a Valplast in the meantime, overly wore it, as you can see. And here we just have our regular, attachments in there. And I use Stellar to pick up stuff. For the acrylic, and he was one happy camper. And if you look at how he was before and after, he was ecstatic. He is 6'7", and he's like, people are looking up at me anyways. I don't care, what they see. He did end up having the lower anteriors done. And so now, things are looking a lot better, but yeah, all he wanted was function, and we were able to get that for him. And he was very happy with that result. So listen to the patients, okay? I know people tell you that all the time, but really listen to what their chief concern is, because it doesn't have to be pretty, but if it's functional, hey, it works. So now we'll go into our last part. So full arch prostheses, we have removable. So we have our overdentures with the locators. This is just a 2-locator overdenture. We have the attachments. So I'm going to kind of go through what, the different names of all the parts are. But typically you see the ones that have the little button inside, and those are going to be 0 is a black color, low retention is blue, medium is pink, and high is clear. Never, ever, ever start with high or medium retention inserts, because now you're getting a patient used to like the highest that it can be, and then they want something stronger, more retentive later on, and you just can't do that for them. Always start with even 0 or low. Then there's extended range inserts that exist. They don't have the little button on the inside of it, and that's for like if your implants are placed a little bit off. Okay. So here I had a case that came in where we did 2 implants on the lower. I used Straumann in this situation, and you can kind of follow the path and see we had our guide. I do everything pilot guided. I was taught to really get a feel for the bone. And then I placed the implants, placed them pretty parallel, did the cover screws and sutured everything up. I had already made the dentures, worked out, all of our occlusion aesthetics, all of that stuff, put a soft liner in the lower denture, and just told her to keep it out, honestly, as much as possible while she healed. Here's the locator housings. So those housings are what's going to get stuck in that denture or picked up in the denture. And then your locator abutments, which again is that connecting piece. Now, instead of between the implant and the crown, it's the implant and that housing for that denture. So you have blockout rings. There's the housing. Inside the housing is where those inserts are going to go into. Just a tip, when you are placing the housings for pickup. So here you see on the left-hand side, there's an attachment, or there's the abutment, and then you have your blockout spacer. And then on the right-hand side, you have the housing over the abutment with the blockout spacer. You want to make sure that you put enough blockout spacers to not have a problem with something getting stuck in there. So you can see on the patient's right, technically, a good example. And then on the left-hand side, a bad example. You should put a lot more blockout spacers in there. You can kind of pile them up, or you can put something else to kind of block out that area. But even so, that implant maybe isn't looking the greatest because you see some threads, but that's another story for another day. So here you see with both the housings. And then you have your special tools, which have a lot of different uses to take out the inserts and put them in and torque down stuff and whatnot. So this is after you pick them up, this is how you can remove the black inserts, and then what you're going to use, or how you're going to use that tool to place the retention of choice. So she was a very happy camper, but we'll skip through that. Overdentures with the bar. So here now you're not relying on the tissue anymore, and you're relying on the bar. So now you're connecting, you're splinting all of the implants and then doing the locator housings over it to clip everything into. And now it doesn't really matter so much what the tissue looks like. So you can do your regular locators, or you can use a hater bar, which allows you to have more rotation, especially in the anterior. Conus is something that is amazing, in my opinion, but basically it's something called, it stays in through friction fit. So you have custom healing abutments, you have Syncone caps that are on the, sort of like they're the housings that are in the denture itself. And they all come together over the custom abutments in order to create that retention for the patient. And it's extremely hard to take out. We actually tell patients to take them out at least, a couple of times a day, just pop them out, put them back in, because otherwise they'll get very settled in there. And with saliva and whatnot, they become very hard to take out. So obviously, if someone has dexterity issues, you don't want them to be using this too much. But this was a patient that came in my fellowship, had a locator FTX hybrid. That's with that ball attachment that you usually see, and it has a really scary tool that you just keep clicking it and then it snaps out, and it snaps the hybrid out, and it's a scary situation in my opinion. She had this hybrid. One of her, you can see there's a healing abutment over on the upper left-hand side because she had some issues over there with the integration of that implant. She would keep it very, very clean. Sorry if anyone's eating dinner, but this, you can see underneath it, and this is why I'm just not a fan of hybrids in general, but they're gross. Now you can see I placed the custom abutments in there and torqued them all down, and her tissue looks beautiful. Now I have those Syncone caps. Again, that's what I'm picking up in that full denture, and that's what's going to stay in there. I've hollowed out everything. I make sure that everything that, nothing's touching where it shouldn't touch. I have my metal reinforcement within the denture itself, no pallet. I picked up those Syncone caps, and that's what the denture looks like, and that's what it looks like in her mouth. So big, big difference. Very happy patient. Another option is Spark Erosion. Spark Erosion is the most expensive option. So basically you have a primary bar and a secondary bar. Those are both milled and very expensive. That primary bar goes into the patient's mouth. The secondary bar goes into the denture itself. And if you look at that third set of pictures, there's a little clip on the inside, which literally is a little latch that the patient can just open, stick the thing in, close it, and now it doesn't move anymore. Okay. Not a very common thing because of how expensive it is. Last case is our fixed hybrid. So this is what a hybrid looks like. There's different ways that you can fabricate a hybrid. So you have Straumann Smile in a Box, Chrome, and then NDX and Sequence. So I will show you an example that I had used with Chrome, though NDX does have, like I said, their own method of this for doing something fully guided and giving, our teeth in a day situation, and that we can offer to patients. And again, this is a whole other conversation, which again, I could do a whole presentation on, but not everyone is the best candidate for a hybrid, but there are people that are. and we really want to make sure that we choose wisely. So this patient had by far the best chief concern that I've ever heard. 71-year-old female tells me, I want to be able to chew a pork chop because now I can only chew a filet mignon. First world problems, right? So patient comes in, this is what she looks like. Her sister was kind enough to pay for having, the top done. And you can kind of see how the implants were placed a little bit there. But this is the day of surgery. Remember, organization is key. And I get, I had planned everything out digitally with the lab, and we have everything ready to go. We have a set of dentures just in case, anything fails. But we'll go into the stackable guides and whatnot right now. So here we lay our buccal flap. Now you can see all of the teeth, and now we have to start stacking the guides. So basically I have my pin guide in place. This allows me to place it over the teeth. So now I know just how high up my fixation base needs to be. And you'll see what that looks like by itself. But here's that fixation base. And now I just want you guys to really picture, you're going to take out those teeth, but you're also going to remove all of that bone. And this is the biggest reason that I am not the biggest fan of a hybrid, because with a hybrid, you need the most space. You need at least 18 millimeters of interocclusal space. So think about minimum is 4 millimeters for a crown. Now you're jumping to 18 millimeters for a hybrid. And that's a lot of bone to take away. So we have our fixation base, and now I can start stacking my guides over it, okay? So I'm gonna take out all of those teeth, and now all of that bone needs to go away. So take my fancy pineapple burr, take down all of that bone, cry a little bit, and then put in my osteotomy guide. This is going to tell me exactly what angles I'm gonna put in those implants. I'm gonna place those 6 implants. Unfortunately, one of them didn't take very well, so I had to cut my temporary hybrid. But this is my prosthetic carrier. I'm putting all my multi-unit abutments in there, covering everything up. So now I can pick it up. I'm aligning it. I've already put marks on the patient's nose and midline, so I know exactly how to angle my temporary hybrid. I put my pickup material in those little holes over there that you see around those multi-unit abutments. I have someone else that's ready and available to clean up that prosthesis while I go and start suturing everything. So over here you see I have healing abutments, and then I just suture around them so I still have access. I don't want to suture everything over and then go fishing for where my implants are. Put the temporary hybrid. You can see it's cut off on the side. She also wanted a valplast on the lower, and we're supposed to take out number 31, but she was tired. So it needed a retreat. She didn't want the retreat, so we decided to extract it, but we did that on another day. This is how she looked immediately after delivery. This is how she looked once a week after delivery. And this was her final hybrid. Unfortunately, COVID happened, and I wasn't able to make her final hybrid for her because I was done with the fellowship, but I met up with her a couple years later, and she let me take some pictures of her. So she was upset she chipped it, but yeah, she was very happy with her result. And back to Minnie to close everything. You have that one patient that I hope, you guys all have an experience in your teams with a patient that really makes a difference in your day towards the positive and has really helped you, become the hygienist, dental assistant, front office, and dentist, that you want to be. And I hope you guys have a Minnie in your life that, has allowed you to do great things. I still kept in touch with Minnie until unfortunately she passed away last year, but I was very thankful to have built a relationship with her and give her that smile that she wanted. And you'll see little by little, they'll stop covering their mouth, once they get that smile. But here she gives a nice wink. That was her wink to get the boys. So thank you so much for giving me this opportunity to speak to you all. I will let Jessica take over, and at the end, I'll put up my contact information. But thank you again.